Dr. Appleby, we'll start. Good morning, everyone, and welcome to our Grand Rounds. It's my pleasure to introduce our honorable guest speaker for today, Dr. Brain Appleby, who has kindly accepted our invitation to come and give a talk and share his perspectives on the current state of affairs on the diagnosis and management of Creutzfeld Jacob disease. Dr. Appleby is the director of National Prion Disease Pathology Surveillance Center, as well as a professor in the departments of neurology, psychiatry, and in pathology, all at Cass Western University, Cleveland Medical Center. Dr. Appleby went to med school at Georgetown University. He then completed his residency in psychiatry from Johns Hopkins, where he went on to do a fellowship in geriatric psychiatry. Dr. Appleby has a special interest, rather vested interest in rapidly progressive dementia, and is a globally renowned leader in the field of Creutzfeld Jacob disease. He is also the medical director of CJD Foundation. And in that capacity, he's a huge advocate for patients and their families when it comes to CJD. Personally, to me, this is a great model as how we as physicians can work closely with patient advocacy organizations and make a difference. On top of all of that, Dr. Appleby is an excellent educator, and by the time we go through this talk, you will all appreciate that. Let's welcome Dr. Appleby.
Well, thank you very much.
Make you the host, sir.
Okay. And thank you very much for the invitation. It's really a pleasure to speak with you all, especially this week. I was reminded that you have a huge weekend. I am a Baltimore Ravens fan, so I really have no preference who wins, but I wish you guys luck this weekend. So. All right. And you guys can see my slides?
Yeah.
Okay, great. So here are my disclosures, research support, some consultancies, and John always talked about the EPSC and the CJD Foundation. So today we'll talk about what is a prion and what is the prion paradigm. And then we'll review some of the clinical features of human prion disease and finally discuss some of the prion disease transmissibility issues or non-issues in the healthcare setting. So first off, what is a prion? That's how these diseases are named nowadays. And basically it's because that is the underlying proteinopathy or pathology of all prion diseases. We all make normal prions, prion proteins, that's called PRPC. Stands for cellular prion protein. That's basically composed of...
Leah, you getting in the car?
See if I can mute this person.
Sorry about that. Please mute yourselves, audience, and people on Zoom.
Okay. So the pathologic prion protein is called PRPSC, which stands for scrapie protein. Scrapie was the first recognized animal prion disease in sheep and goat. And it's characterized by the same amino acid sequence. The only difference is the 3D conformation. You'll see on the right-hand side this more beta-pleated sheet structure. And for reasons that we don't completely understand, that allows it to be not only transmissible, but also neurotoxic. So the prion paradigm, which now is being applied to many other neurodegenerative illnesses, states that we have this normal cellular native prion protein, PRPC, the yellow dots, that comes into contact with the disease-associated form, PRPSC, the blue dots. And the prion paradigm basically states that the abnormal prion protein converts the normal prion protein into itself in this autocatalytic cycle. So the seed would be the abnormal prion protein that, again, finds the normal one and then keeps amplifying and replicating the abnormal form of the disease. Think of it as the bad kids on the schoolyard are recruiting the good kids for their gang. That's exactly what happens. And of course, most of the talk of the prion paradigm nowadays is centered on other proteinopathies like alpha-synuclein, TDP43, tau, amyloid beta, and truth be told, they do propagate in this manner, at least in vivo. There is one important difference between prion diseases and these other proteinopathies, and that is these other proteinopathies have not demonstrated any individual transmission or transmission across species. So that makes prion disease itself unique as these protein misfolding disorders. So the only way to definitively diagnose prion disease is by neuropathologic examination. And there are a couple of hallmarks that we find. First, if you do H&E staining, you'll see these large vacuoles, which give rise to a sponge-like appearance. Prion disease were first called transmissible spongiform encephalopathies because of this sponge-like appearance of the brain parenchyma. Then you can treat the brain tissue with protease K. One of the unique features of prions is that they're very resistant to protease treatment. All other proteins will be degraded, but prions themselves will remain. So if you treat the brain with protease K and then you add an antibody against the prion protein, it will bind to it. So on immunohistochemistry, you'll see these deposits of protease-resistant prion protein. And then another thing you can do, again, is looking at the protein itself, is you can treat brain homogenate with protease K and see whether or not abnormal protein remains when you use antibody against the prion protein on Western blot analysis. So one of the key features is at least the partial protease resistance of the prion protein, which again is unique to any other protein. So hopefully you understand just the bare basics of prions and prion biology. I would argue that as clinicians, we don't need to know the deep dive of that, but it is important, I think, to understand the general basics, as that does apply to a lot of the clinical features of the illness. Now we'll move on to some of the clinical features of human prion disease as a whole. Most people think of prion disease and they think of acquired forms of the disease, specifically mad cow disease. However, the most common cause of prion disease in all countries is what we call sporadic or idiopathic. What that means is we have no known cause of these illnesses. We don't think they're transmissible. We know they're not genetic. And there's precedence for this in other neurodegenerative illnesses, right? Most Alzheimer's disease, most Parkinson's disease, most ALS and FTLDs are in fact sporadic and age associated. So this is not unique amongst neurodegenerative illnesses. So about 85% of prion disease is sporadic in etiology. That's followed by about 10 to 15%, more like 10% in our country, of genetic forms of the illness. And genetic forms are caused by a disease-causing mutation in the prion protein gene that expresses the normal cellular prion protein. And there are a couple of different names for all of these, so they're really not that important. And the reason why they're differentiated is because of different, basically neuropathologic phenotypes, and then sometimes clinical phenotypes as well. Now that's important for my job, in that this is how we do surveillance, is by recognizing known forms of prion disease and making sure we don't have new forms. As a clinician, it is somewhat important because some of these phenotypes behave differently clinically and also diagnostically, but at their basis, they're the same. They're due to abnormal prions. So the vast majority of sporadic prion disease is what we know as sporadic CJD. Then there's other forms called variable protease sensitive prionopathy and sporadic fatal insomnia, but they're extremely rare, making up just slightly over 1% of all sporadic cases in our country. Similarly, with genetic CJD, the vast majority of those phenotypes are what we call genetic CJD, which, as you would expect, resembles the classic phenotype of CJD. But there are other named phenotypes called fatal familial insomnia and Gershman-Straussler-Schenker syndrome, which we'll talk about later in detail. And then finally, the ones that we hear about the most in the media, and perhaps are the most frightened about, the acquired forms or the infectious forms, are thankfully the least common. In our country, under 1%. And this includes illnesses such as Kuru, iatrogenic or medically transmitted CJD, and then variant CJD, which is what we call mad cow disease transmitted to a human. And again, we'll talk about these in detail later on. Prion disease in general is a disease of mid to late life. However, if you categorize different prion disease based on their etiology, you will see some characteristics amongst those categories. So for example, most cases with variant CJD at least were young in their teens, 20s, and 30s. Most cases of genetic CJD tend to clump around more mid-age, and then most cases of sporadic CJD tend to be more later life, with a mean age of onset of about 62 years of age. However, it's important to remember that although there are some general characteristics amongst these categories, there's a wide breadth of variability. So for example, in our country, we've had sporadic cases of prion disease as young as 14 and as old as 103. So these are averages with a lot of variability. Most people recognize that prion disease, especially CJD, is a very rapidly progressive illness. This is an example of that. This is a Kaplan-Meier survival curve of patients with CJD over a long period of time. And what you'll see is that the mean illness duration amongst all prion diseases, especially CJD, is about 4 to 6 months, and that's from illness onset until death. The average time from diagnosis to death is about a month, and that's because, as we'll see later, it's difficult to make the diagnosis because the clinician has to have some reasonable clinical suspicion to start investigating the diagnosis. And as it is with other neurodegenerative diseases, perhaps our most helpful diagnostic tool is time. So it does take time to develop that clinical suspicion. What you will also see is that about 1 year out from illness onset, 20 to 25% of patients are still alive. And I call this to your attention because a lot of times we say that so-and-so patient can't have CJD because they're still alive after a year. Now, it's true that most people will have passed within 1 year of illness onset, but it's also true that you will see a certain percentage of patients, about 25%, that will live longer than a year. So it should still be under differential, especially if other diagnostic tests are suggestive of prion disease in patients that are still alive a year after onset. And you'll see here that occasionally you'll even see people that live longer than a year, 2 years. That's unusual, but again, it does happen. Epidemiology, most people know the 1 per million number in CJD. It's important to remember that that is an epidemiologic statistic. It's what we refer to as an annual incidence. So that demarcates the number of new cases of CJD that occur every year across the general population. But as you've seen in earlier slides, the general population as a whole does not develop CJD. It's mainly mid to late life individuals. So if you were to stratify annual incidence by age, you'll see that it drastically changes as people get older. So across all ages, it is about 1 to 2 new cases per year. Under 65 years of age, as you would expect, it's drastically lower than that. But in patients over the age of 65, that annual incidence increases to about 4 to 7 per million per year. Incidence is very important from public health and epidemiologic standpoints. I think sometimes it can be misleading to us as clinicians, as well as also to family members. So a statistic that I like to refer to more commonly when I talk to clinicians and especially families is how many deaths occur every year in the US due to prion disease. This is a frequency. It's also a lifetime frequency. So if you look at that statistic, about 1 in 6,000 US deaths every year are due to CJD. So this says a couple of things. Number one, I think it's more psychologically congruent with what actually is occurring as opposed to a public health statistic. But also it connotes a couple of things. It is a rare disease, but perhaps not as rare as people would think with that 1 in a million number. So for example, at the Super Bowl this Sunday, I don't know how many people will be in the stadium, maybe between 20, 30,000 people. You would expect a handful of people that are in that stadium to develop CJD at some point during their lifetime. That's actually expected. So let's look at Pennsylvania. Pennsylvania, according to Wikipedia at least, has 13 million people. So we would expect, again, 1 to 2 new cases every year of prion disease across that 13 million people. So that would be 13 to 26 new cases every year. If we assume that 25% of cases live longer than a year, that's going to be a carryover of 3 to 6 cases every year. So it wouldn't be unusual, and actually would be expected to have anywhere from 16 to 32 active cases at any time in the state of Pennsylvania. So again, especially as neurologists, especially in academic medical centers, you should be seeing these cases actually fairly regularly, definitely every year, if not every month or every couple months. Oftentimes we're asked to give these talks because people have noticed a lot of cases, and they'll say, I've seen 10 cases in the last year. First off, that's a good thing, because that means that my education really is not needed, because you're at least looking, right? Which is excellent. But it also brings into question whether or not these are what we would call disease clusters. We know CJD is transmissible under select circumstances. So do these cases that we're seeing in group have some type of collective commonality or risk factor that's giving rise to them? So I do think it's somewhat interesting to talk about how we investigate potential clusters in this country. These are primarily investigated by the CDC and local health departments, but we are usually involved as well because we have a lot of the diagnostic tests. And these are the steps that are taken to investigate the cluster. First, it's very important to verify that they're prion disease. Oftentimes, we will examine these cases and find out that, yes, the initial suspicion for this case was prion disease, but it actually wound up being another etiology. Well, if that's the case, it doesn't belong in the cluster. We then also have to verify what type of prion disease it is. So if you have a cluster of 5 cases, but 2 or 3 of them are genetic etiology, again, you know the etiology of those cases. So you kind of have to exclude them from a cluster because they're not unknown. There's a known etiology because of the mutation. And it's also important to do that because, of course, families aggregate together. They usually live together. So it's not uncommon to see aggregates of genetic cases, whether or not they even know that they're related to one another. And then, of course, we want to look at those cases that are carried over from that investigation and see whether or not the incidence is higher than what we would expect. Does it still fall within the 1 to 2 per million per year in that population that we're looking at? And then we look at the likelihood of a common exposure, right? So are they all venison consumers? Are they all hunters? Did they all have neurosurgeries? Things like that. That's when we start looking at these exposures. And then, of course, we have to verify that the incubation period makes sense. One of the characteristics of prion disease is this very long incubation period. Gave rise to its initial term of a slow viral illness. This before we knew it wasn't a virus, because from the time of exposure to the time that people get sick generally is measured in years, not months, not days. So when the COVID-19 pandemic and the vaccines came out, we were inundated with calls about whether or not COVID or the vaccine causes CJD. And when we started looking at these cases, the implication was that the patient started developing symptoms immediately after developing COVID or immediately after getting one of their booster shots. Well, that doesn't make sense for the illness biology, right? You don't expect to see a sudden change like that. Even if the vaccine were to prompt misfolding, it still takes time for the accumulation of the abnormal prion protein to cause damage and to cause clinical symptoms, just like with things like we see with Alzheimer's disease and Parkinson's disease. There is some delay from pathology accumulation until clinical disease. So how do we diagnose probable CJD in a living person? We said earlier the only way to definitively diagnose it is by autopsy, and that is important, but of course that doesn't help the patient or the family while they're alive. Fortunately, nowadays, we have very good diagnostic tests and clinical criteria that can be used. I'm going to review some older criteria that can still be used and still should be used, but I'm also going to refer to some newer criteria that I would argue has really changed the landscape of diagnosing prion disease. So the older criteria really follows the paradigm of other neurodegenerative illnesses, which is the clinician has to synthesize a syndrome, a collection of clinical symptoms that are suggestive of underlying pathology. And then that guides them to perform different diagnostic tests to either confirm or refute that hypothesis. So with CJD, the clinical syndrome would be at least two clinical signs with dementia. And there's other clinical signs that include myoclonus, include cerebellar or visual symptoms, pyramidal or extrapyramidal symptoms, or then late stage akinetic mutism, which I would argue is not super helpful for the diagnosis of CJD in a living patient because it's a very end stage characteristic. And you also will see it in other cortical types of dementias. And then, of course, you pair that with some type of suggestive diagnostic test. Everyone is familiar with periodic sharp wave complexes on EEG, which I'll show you later on. Of course, the 1433 and spinal fluid with a disease duration less than 2 years. We'll definitely talk about that. And then more recently, around 2009, we started using brain MRI criteria, usually on DWI sequences of high signal abnormalities located in the basal ganglia and or at least two cortical regions, excluding the frontal lobe. And these are helpful criteria, don't get me wrong, but one of the downsides of these criteria, again, is the requirement of the germination of a clinical syndrome. Again, that takes time, and that's going to delay the diagnosis. But around 2018, criteria was added for a new test called RT-QuIC, which stands for real-time quaking-induced conversion. And we will talk about this, but it's important to know that this is an extremely specific and, more importantly, a disease-specific test that is so specific that it actually really rules out the need to have a full clinical syndrome suspicious of CJD. In fact, a probable diagnosis of CJD can be made if you have a positive RT-QuIC, basically in the setting of any neuropsychiatric symptom, of course, as long as the other things are ruled out. Now, as you can imagine, this is unique in the neurodegenerative space because we now no longer need a full flourished clinical syndrome for our neurodegenerative illness. We just need one symptom tied to an extremely specific test. One thing to remember is we talk about the clinical syndrome of CJD, but as I've alluded to before, almost never will a CJD patient initially or very quickly develop clinical syndrome of CJD. So if you look within the first week or so of clinical symptoms, almost no one has that full clinical syndrome of classic CJD of dementia, myoclonus, and ataxia. It's only about 13% of cases. The plurality of cases will present with isolated cognitive syndromes. It may look like a atypical dementia, for example. It's about 17% will present with a pure visual presentation. We call this a Heidenhain variant. And these are actually usually very quick cases, and they're often misdiagnosed as a stroke because of that DWI diffusion abnormality with very quick onset of visual symptoms. And then 15% may actually present with a nonspecific mood disorder like depression or bipolar disorder or anxiety. So again, patients aren't coming to the clinic usually with a clinical syndrome of CJD. So what should raise your clinical suspicion, and what patient population should you add or at least heavily consider the possibility that someone should have prion disease? And I would postulate the following. People at risk of prion disease. So if you know that there's a family history of it, or you know that they had a known exposure to a transmissible risk factor, then it certainly should be on your radar. If you have someone with dementia that have other atypical neurologic symptoms, so things like ataxia, myoclonus, which especially early in the disease course, which you do see those things in other dementias, but they're not typical, right? And usually you see them in more atypical forms. So if you start seeing those things in any dementia, I think it's worth at least being on your differential. And of course, if you see any rapidly progressive neurodegenerative disease, it should be on your differential. And then there are some of these odd cases, right, that live longer than a year, again, about 20–25%. And they often start out looking like an atypical dementia, like an FTD or a dementia with Lewy bodies. But along their disease course, they start becoming a little funky looking. They become atypical. And in those cases, that might be a good reason to revisit your differential and start thinking, well, could this be something like prion disease? And then, of course, if you happen to have done any type of workup that would include any of the diagnostic tests that we would use for diagnosing prion disease, and they're suggestive of that, you certainly should pursue that, even in someone where you don't have a clinical suspicion yet of prion disease. So this is an example of periodic sharp wave complexes on an EEG. Oftentimes nowadays, we do not diagnose CJD based off of EEG findings. We're mainly using EEGs to rule out other etiologies. And that's simply because not all cases of prion disease will develop periodic sharp wave complexes. And if they do, it's usually only certain part of the illness where they'll be manifest, usually about 2/3 of the way through the illness. And again, only in some cases. When you see them, they're fairly specific for prion disease. But again, if you don't see them, it certainly doesn't mean that the patient doesn't have prion disease. Brain MRI, which in my opinion has really revolutionized the earlier diagnosis of prion disease, it definitely has increased the ascertainment of prion disease cases. And again, the important sequence here is DWI, and you'll see hyperintensity in either the basal ganglia, the caudate and putamen, or in the cortical ribbon of pretty much any cortical lobe except for the frontal cortex because of the artifact that we often see here. And what's important is there should be an ADC correlate to the hyperintensity on DWI. And that's important because it often helps us differentiate prion disease, where you would expect to see the ADC correlate, from other mimickers of CJD on MRI, such as things like autoimmune encephalopathies. The reason why I think this has really changed the early diagnosis of prion disease and the ascertainment of cases is because this has resulted in increasing physicians' clinical suspicion of prion disease when otherwise it might not be suspected, especially in memory clinics. So of all the cases that I've diagnosed de novo of prion disease, not people referred to me suspected of that, it's been in a memory clinic because that's primarily what I do. And it was someone who I ordered an MRI on for, typical evaluation for dementia. And this is what their MRI looked like. And I would have never had any clinical suspicion of prion disease because I only had dementia, didn't have anything else. And it wasn't really reported as rapid at the time. But of course, if the MRI looks like this, I'm certainly going to go down further investigations of prion disease. We do have a variety of cerebrospinal fluid tests. The Prion Center is our nation's reference lab for clinical diagnostic for CSF. And we have a Prion panel where we automatically do 3 tests anytime CSF is sent to us. 2 of them are what we call surrogate markers of neurodegeneration. That includes 14-3-3 and total tau. I know we do 14-3-3, but I'll be honest with you, as a clinician, I do not look at 14-3-3 anymore. I think it's extremely misleading. It's too sensitive. Almost all the cases we get at the Prion Center will be 14-3-3 positive just because of the differential. And it's just an indicator of badness in the brain. But again, if you're sending it to us, that's happening. So again, I would advise not looking at 14-3-3. We still include it because we really want to capture those people that don't have the education of these other diagnostic tests. And that's why we do all of them, no matter what gets ordered, because we want people to have access to the better tests. So I don't look at 14-3-3 because it's too sensitive and not specific enough. Total tau is also sensitive, but it also is not specific, although its specificity is greatly improved over 14-3-3. But again, RT-QuIC has really become the most important CSF test that we do now because it actually detects the abnormal prion protein itself in the CSF, making it disease-specific and highly specific. So what is real RT-QuIC? Well, unfortunately, despite the acronym, it's not quick. They really should have come up with a different name. It takes 60 hours to run. And the reason why that is because RT Quick takes advantage of the Prion paradigm. Perhaps a simplified way of viewing this, it's kind of like a PCR for proteins. So the way it works, we take a 96-well plate, we add recombinant normal prion protein, which will be the substrate for the reaction. We add the sample, which presumably has disease-associated prion protein. And then we add thioflavin T, which will bind to any fibrils that form during this reaction that would be indicative of abnormal seeding activity or the presence of an abnormal prion protein seed. We added in an incubator and a shaker for 60 hours. And again, the kinetic energy and the thermal energy in this, if there is prion protein in the sample, will cause the abnormal prion protein to convert the normal prion protein into itself. If that happens, oligomers will form, fibrils will form, thioflavin T will bind to the fibrils, and then you'll get these real-time phosphorescent curves. So this is an example of brain homogenate. We do 4 wells for every case. So you see the curve goes up immediately because of the amount of abnormal prion proteins in the brain. These flat lines are not prion disease. They're not seeding. And then you see 2 positive cases here where basically the abnormal prion protein is converting the normal prion protein into itself. The thioflavin T is binding to it, and you're getting these phosphorescent curves. So if you look worldwide, there's several laboratories that do RT Quick. Almost all of them are in surveillance centers. It's reliably specific. And it's also pretty sensitive. So again, if you compare it with 1433, there's no comparison in sensitivity, and especially not specificity. Now, you'll notice that the specificity of other countries are almost always 99 or 100%, and ours is slightly lower than that. And the reason for that is the way our country handles CSF testing is somewhat reliant on the US healthcare system. So these other countries that are running RT Quick are usually national, have socialized or national medicine. So they have infrastructure for things like screening samples before they're sent to them. And so they're actually screening RT Quick cases before they accept them and doing it. So their pretest probability is much higher. In the US, we know nothing about our patients essentially, and we test everything. So because of that, we're kind of shooting in the dark, and that probably lowers our specificity slightly, but still a specificity of 98.5% is pretty good. So a very common question we get at the Prion Center is, what should I do in a case that's 1433 positive, the tau is elevated, but the RT Quick is negative? One of the downsides to having this powerful RT Quick test is that everyone really wants it to be positive in their case, right? Because it really helps with the diagnosis. But we have to remember that 10% of CJD will be negative by RT Quick normally. And there are other things that will also result in the negative RT Quick result, such as quality of the specimen. If it's bloody or slightly bloody, it will decrease the sensitivity. So again, just because the RT Quick is negative doesn't mean it's not prion disease. And these are some other things you can do if you're stuck in this situation. So first off, you should always re-examine the diagnosis. I always like to say that the first rule of diagnosing CJD is not diagnosing CJD, right? You want to make sure that you're not missing something, because a lot of the illnesses on the differential diagnosis of prion disease are treatable, and you certainly don't want to miss that. So by re-examining the diagnosis, you want to look at the clinical phenomenology. Does it jive with prion disease? Does it jive with other illnesses that we haven't investigated yet? Did you complete that $1 million rapidly progressive workup yet? Rapidly progressive dementia workup is extremely extensive. And I would argue that you look in Continuum or any of these review articles, you keep a copy of it on your phone, or you make an order set for it, because there's no way you're going to remember everything on that workup. It's very extensive. Even myself, I have a order set that I can just click and don't have to remember everything, because I know I'll forget something. So just make sure that you've done all those tests that are suggested, and those excellent reviews. And then, of course, anytime you order so many tests, it's almost certain that you're going to get some positive findings. And of course, some of those positive findings may be incidental, but you really should follow up on them. Make sure that it's not indicative of something else going on, especially if you're in this scenario at the top of the slide. Then the other thing you can do is look at other tests that are suggestive of prion disease. So do you see periodic sharp wave complexes on EEG? Is the brain MRI suggestive of CJD? Keep in mind, you can still make a probable diagnosis of CJD in a case that's RT-QuIC negative if any of these two biomarkers are positive, of course, in the clinical syndrome of CJD. That's still just as reliable as a positive RT-QuIC. So don't be afraid to make that diagnosis if the patient is fitting that. And then, of course, there are other atypical prion diseases that we haven't touched on too much yet, but they're important because oftentimes the diagnostic tests that we use for classic CJD, like sporadic CJD, may not be helpful in these phenotypes. So that includes things like fatal insomnia, GSS, and variant CJD. And we'll talk about some of the diagnostic process of those illnesses later. Keep in mind that we did a study that encompasses 3 years, and this is very, I think, helpful. I use it all the time in clinic and when people call the center. Over 3 years time frame, all the cases that we saw with sporadic CJD, 100% of sporadic CJD were positive by either RT-QuIC or brain MRI. Now, I say greater than 99% because nothing's 100%. You're always going to see an outlier. But in those 3 years that we looked, it was 100%. So I think that's very reassuring. So, having the RT-QuIC and the brain MRI combined, it's 100% sensitivity. So keep that in mind when you look at patients. And don't forget the value of the brain MRI. You can still make a clinical diagnosis that's equivalent to RT-QuIC in that probable diagnosis. So moving on to genetics, again, all genetic forms of prion disease are due to a genetic mutation of the prion protein gene, PRNP. And you'll see in this schematic that everything above the gene in the red are pathogenic mutations. These are disease-causing mutations. They cause the illness. Everything below are what we call polymorphisms, which are risk factors. So in our field, we always look at something called codon 129 because it has tremendous effect on the incidence of sporadic illness, but also the clinical phenotype. But it is not a disease-causing mutation. So keep that in mind. And as you'll see here, there's a lot of different pathogenic mutations for genetic prion disease. There are probably about 50 or 60 at this point. But what's also to remember is not all genetic mutations are created equal. So one thing that's very important, especially when you see a family that's affected by genetic prion disease, is that the penetrance can vary quite widely depending on what mutation it is. So it used to be thought that genetic prion disease had 100% penetrance. And again, penetrance is the likelihood that you'll develop the disease if you carry the mutation. However, we now know that's not true. Yes, the kind of classic genetic forms of prion disease do have pretty close to 100% penetrance, right? That includes FFI, GSS, and E200K, the most common form of genetic prion disease, are very, very close to 100%, if not 100% penetrant. And as you would expect, if it's 100% penetrant, they're much more likely to have a family history of prion disease. But what's also important, remember that other genetic mutations don't have that high of a penetrance. So in your area of the country, especially the New York area, the B210I mutation is quite common. These are usually from Italian heritages. What's important to know about that is even though we consider it genetic prion disease, the penetrance of this mutation is only about 10%. So very rarely do you actually see a family history. Now, this is important for people that want to do predictive genetic testing in someone that they found out had this mutation, because the likelihood that they will develop prion disease, even if they're found to carry the mutation, is unlikely. They're still more likely to not develop the disease. There are even some mutations where the penetrance is 1%. So just keep that in mind. If you come across the case of genetic prion disease, you see the mutation, you want to know the penetrance before you talk to the family, you can always call us. We'll give you up-to-the-date information on what that penetrance is. We also talk to genetic counselors all the time about that because we want families to really be appropriately informed so they can make a decision on whether or not they want to do predictive genetic testing. So genetic CJD is the vast majority of the clinical pathologic phenotype of all genetic prion diseases. It very closely resembles genetic prion disease. The most common mutation is E200K, making up about 60% of all cases. It's very similar to CJD, and all the diagnostic tests that we typically use will be positive for the most part. Fatal familial insomnia is due to a very specific mutation haplotype, D178N, when it's coupled to methionine and 129 of the mutated allele. This disease primarily affects the thalamus, so that's where you get a lot of the classic symptoms of insomnia, pretty profound neuropsychiatric symptoms, autonomic instability. They will sometimes develop dementia myoclonus, but it'll be later in the disease course. Now, unfortunately, a lot of the diagnostic tests that we use for sporadic CJD will be negative in FFI. That includes things like the RT-QuIC, EEG, and MRI. So how would you diagnose these patients? Well, again, if it's genetic, the most likely way you're going to do that is through genetic testing. But brain FDG PET or SPECT scan can also be helpful because you'll see focal thalamic hypometabolism, or you can do a polysomnogram, which will see a complete disruption of the sleep-wake cycle. So this is an example of what a FDG PET would look like in a FI case, and keep in mind there is a sporadic equivalent to fatal familial insomnia. It's very rare. I think we've only had 32 cases in this country since 1997, but very closely resembles everything that I'm talking about with FFI. And then we have GSS, which in my opinion doesn't look like a prion disease at all clinically, and because of that is probably under ascertained. Typically, you'll see isolated cerebellar or Parkinsonian signs early in the disease course that may last in isolation for years. You can develop dementia, but that's usually very late in the illness. And again, much longer duration. The mean duration for GSS is 5 years, but there have been cases up to 20 years. CSF tests, EEG, brain MRI are often negative, but there's some variability with this, and it's not quite the dire situation that you see with FFI. CSF RT-QuIC is positive in about 2/3 of cases of GSS. MRI is also common and positive in about maybe 50–75% of all cases. Again, I think these are under ascertained, especially under ascertained in movement disorder clinics. A lot of these patients are misdiagnosed as a spinal cerebellar ataxia of unknown mutation. And so if you have someone that resembles a SCA or like PSP or CBD, there's a family history, but you can't find a mutation, please consider doing PRNP testing to see if it's GSS. So a lot of times people ask, well, why would you even want to do predictive genetic testing? It's a fatal illness without any treatment. But of course, that may change. People want to participate in research. Oftentimes you need to know your mutation status for that. And then the other reason is sometimes people want to have biologic children and know that that biologic child does not carry the mutation. And we see this with other genetic neurodegenerative illnesses as well, something called pre-implantation genetic diagnosis using IVF, where you do IVF but only implant the embryos that don't have the mutation. It eliminates disease from the family. You can even do this if the parent doesn't want to know their genetic status. So moving on to acquired prion disease, most people know the story of Kuru. This is really where our understanding of prion disease started. We knew that it was transmissible. It basically occurred in the Fourier linguistic group of Papua New Guinea. It was transmitted through ritualistic endocannibalism. And one of the most important things that we learned about Kuru is the incubation period for prion disease, which in the case of Kuru has been up to 52 years from the known exposure date to the time that they developed symptoms. Of course, you can kind of do this medically in an iatrogenic setting. Fortunately, we don't see much of this anymore. Most of these cases of medically transmitted CJD is from reuse of cadaveric material, where the cadaver actually had been infected with CJD. So that includes, in our country, cadaveric human growth hormone, which we don't do anymore. We use recombinant human growth hormone. dermatographs, which sometimes still come from cadavers, but most are synthetic. We can also do corneal transplants. We mitigate that risk by all corneal transplant donors are usually screened for a neurologic illness and excluded if there's any neurologic illness. So really the only pertinent remaining real-time risk for iatrogenic CJD currently would be neurosurgery. So again, CJD is transmissible, but it's under very specific circumstances. You basically have to take brain tissue and touch other brain tissue with it, ingest it in large quantities, or inject it in large quantities into a person. You'll see at the very bottom blood transfusion, but that is a very specific use case scenario, and that's variant CJD. Variant CJD, mad cow disease in humans, is very different. It resides in lymphoreticulae tissues, so it is very commonly in the blood. And all cases of known transmissions of blood-based transmissions of CJD have been in variant CJD. There's been no epidemiologic evidence that non-variant forms of CJD, like sporadic or genetic forms, are transmitted this way. So variant CJD, again, due to eating meat contaminated with mad cow disease or BSE, typically presents in young individuals. They have longer illness durations, early psychiatric symptoms or sensory symptoms. They have a different brain MRI profile. It's called the Pulvinar sign, or the hockey stick sign that you see in the corner here. Usually it's most apparent on flare as opposed to DWI. And what you'll see is isolated hyperintensity of the pulvinar nucleus of the thalamus that's more hyperintense than the caudate and putamen. You can see hyperintensity in the thalamus of sporadic CJD cases, but it should be brighter on DWI compared to flare. And you'll often see other hyperintensity in other regions of the brain, whether it be caudate putamen or the cortex. Although millions of people were exposed to mad cow disease, then we'll get to your question in a second, Tim, because it's an important one. And there's a lot of misinformation about it. Despite millions of people being exposed to variant CJD, fortunately, only 233 cases have been identified of variant CJD worldwide to date. Mad cow epidemic started in UK, so most of these cases are in the UK, followed by other European countries. There have been 4 cases of variant CJD in the US, all of which were thought to have been acquired overseas. There's a very long tail to this, as you would expect when we see with Kuru. We definitely see a diminishment of variant CJD incidents over time. But again, like with iatrogenic, like with Kuru, there's going to be a very, very long tail. So one could hypothesize there's millions of people that are exposed, but only 233 people are symptomatic with variant CJD. What does that mean for other people that are exposed? Are they asymptomatically incubating the disease? So the UK did this survey of appendices, because again, variant CJD resides in lymphoreticulae tissues. They looked at over 30,000 appendices, 16 were positive for prion disease. There's no difference by birth cohort, which is a little bit weird. Doesn't matter whether or not they were born before or after the BSE epidemic. Doesn't matter their genetic makeups. All of them were represented. So there's an estimated infection prevalence of about 1 in 2,000, 1 in 4,000 Brits are asymptomatically incubating variant CJD. So this is why when you give blood, they ask you whether or not you've been in the UK, because you would be at risk of possibly being an asymptomatic variant CJD carrier. Now, truth be told, the vast majority of these people will never develop variant CJD, but they could potentially transmit it through blood transfusions to another person. Fortunately, in our country, we don't have a lot of mad cow disease, but we do have a prion disease of chronic wasting disease and cervids. So these are basically rodents with antlers, so deer, elk, moose, caribou. It's a widespread epidemic amongst cervids. There's no way to stop it. These are free-ranging animals. It's kind of a disaster from the animal standpoint. Of course, the concern is that it could be transmitted to humans. We have no evidence that it has transmitted to humans, but doesn't mean that it won't. Again, long incubation periods mean that people could be infected already and haven't developed the illness, but also, as you see with any fulminant disease that is rampant, like CWD is, you could get strain variation, and different strains could be more infectious than others to humans. So this is why autopsy is so important, because that's the only way we're really going to be able to identify whether or not the strains are different from commonly known strains and whether or not CWD is transmitting to humans. Experimental treatments, unfortunately, there's not much. Prior studies include quinacrine, tricyclic compounds, doxycycline, pentosan polysulfate. All of these were postulated to reduce or block the conversion of the normal prion protein into the abnormal form. They all were negative. Future studies are going to be focusing less on that and probably more regarding genetic approaches. Again, you need to have the normal prion protein to have prion disease. So a lot of these future treatments will probably address that. And then maybe we'll see some targets for reducing neurotoxicity. Symptomatic treatment, just your basic geriatric medicine, geriatric neurology, psychiatry, what have you. Try to do behavioral interventions first. If you have to use medications, start low, go slow, and be very mindful of exacerbating neurologic symptoms, especially with neuroleptics and Parkinsonism. All right, so I'm going to end with disease transmissibility in the healthcare setting, and this will somewhat jive with Tim's question. I like to lead off with a quote from my predecessor, Dr. Gambetti. He would frequently say the fear of prion disease is more infectious than prion disease itself. This is a fact. People are terrified of the illness, and again, not without cause, but it's important to remember that transmissibility requires very specific scenarios in which you're not going to encounter in routine clinical care or family is going to encounter in their care. So in routine clinical care, standard precautions only, no need for gowns, mask, isolation. And again, consider the family. This is what's being said. And if you come in a mutant suit, they're going to notice that there's a discrepancy between what you're doing and what you're telling them. This differs, however, if you deal with highly infectious material, brain tissue. So there are very specific circumstances that you have to take for surgery and equipment that are exposed to brains of contaminated prion disease patients. Too much to go into. There's a lot of guidelines for this, but it's important to remember for transmission to occur, you have to have high infectivity tissue, you have to touch other brain tissue, you have to either ingest it or inject it in large quantities. That's not going to happen unless you're doing something very weird. And as far as physicians, there was a very, very large study that looked at physicians across Europe. Physicians were not any more likely to develop prion disease than any other population, any other occupation, or the general population as a whole. And that include neuropathologists and include neurosurgeons. So again, yes, they deal with brain tissue, but they have to be in a very specific circumstance where they're going to actually be in that scenario where it can be transmitted. And most neuropathologists, most neurosurgeons, again, if they're doing the right thing, they're never going to be in that kind of compromised position. So in summary, there are three main causes of prion disease: sporadic, genetic, and acquired. Clinical presentation can be variable, but is usually distinguishable from other neurodegenerative conditions. Neuropathologic examination is the only way to definitively diagnose and type the prion disease. And nowadays, we're very fortunate. We have very reliable clinical diagnostic tests for prion disease, especially with brain MRI and RT-QuIC. So if you don't pay attention at all to this talk, please wake up now and take this away. And that is, in our country, we have a lot of resources for patients, families, and physicians, and public health departments, and infectious disease, operating theaters, what have you, through the National Prion Disease Pathology Surveillance Center. We will coordinate and pay for all autopsies of suspected prion disease in this country. All you have to do is let us know. We'll guide you towards the consent forms that the family members have to fill out. It's out of your hands. We take it from there. Very important, again, for epidemiologic surveillance of things like chronic wasting disease, but the family also gets genetic verification, whether it's genetic or not. We do clinical reference testing for CSF and genetic testing. And we also have a free brain MRI consultation program. We'll look at the brain MRI for you, let you know whether or not we think it's prion disease. CJD Foundation is an excellent resource for patients and families affected by this illness. It is geared very much towards the families, which it's actually very hard to find literature on this illness that's not, that is lay specific. So they're an important resource for that. And of course, CDC has excellent resources, and you can always reach out via phone or by email. So I think I will stop there. And if we have time for questions, I'm happy to take them.
So we have a few questions, I guess, in the chat.